So simple bone cyst is also known as unicameral bone cyst. It's a relatively common benign tumor-like fluid-containing lesion of unknown cause, usually occurring in the metaphyseals of long bones, and it accounts for about 3% of all bone tumors. There is a male preponderance, about 2:1 ratio. 85% of them are seen in the first 2 decades of life, and the peak incidence is from 3 years to 14 years. In patients below 20 years of age, about 55 to 65% are seen in the proximal humerus, about 25 to 30% are seen in the proximal femur. So, in fact, the proximal humerus and proximal femur account for almost the overwhelming majority of simple bone cysts that we see, and rarely you may see it in the tibia, in the ulna, in the fibula and the radius. In patients above 20 years of age, you see this in the flat bones, particularly the ilium and the calcaneum. Cysts that present in the first decade of life are considered to be more active, that they are likely to continue to grow. So, how do these cysts present to you? Well, by themselves they are asymptomatic. In fact, they are not even considered as true tumors, they are considered as tumor-like conditions. It is in fact just a faulty formation of bone, so it is not an active pathology. So, in majority of these cases, either they are noticed incidentally on an X-ray done for some other cause, particularly a chest X-ray done for any chest complaint, and you see something in the humerus, or they present suddenly. Suddenly means when the child is playing or doing some activity at home, he suddenly hears a snap or a crack and gets pain and is unable to use that extremity, and that is how 2/3 of these patients present to us. And quite a few of them will also come with history of repeated such incidents, and the interesting part is the gap between these incidents may be months or even years, and they are absolutely asymptomatic during that time. So, the first thing that we do is always an X-ray whenever a patient comes with such a complaint. So, what we see is that these cysts are found in the proximal metaphysis or metadiaphysis of long bones, particularly the proximal humerus and the proximal femur. Diaphyseal lesions are relatively rare, that is about 4 to 12% of these patients. On an X-ray, it appears as a radiolucent lesion which is centrally located, slightly expanded. It is well circumscribed geographic lesion with thinned out cortices and very narrow margins. So, it has got a typical benign appearance. There is no periosteal reaction and there is no soft tissue extension. Whenever there is a pathological fracture, in 20% of those patients, you will see a very typical sign which is almost diagnostic of simple bone cyst, which is called as a fallen fragment sign. The other interesting thing is these cysts may be either very close to the growth plate or they may be away from the growth plate. Depending on that, if the cyst is within a centimeter of the growth plate, they are referred to as active cysts. Active means they are likely to continue to grow and they are more likely to recur after your treatment. Whereas those cysts which are more than a centimeter away from the growth plate are considered as latent cysts. They generally don't tend to grow and they are more likely to respond to your treatment. So, this is a typical X-ray of a proximal humerus and a proximal femur simple bone cyst. This is where you can see the fallen fragment sign in the proximal humerus and distal fibula simple bone cyst. So, what is a cause? This has always been a debate and it has not been resolved. In fact, we could have debated on this. The specific etiology of UBC has not been resolved so far. There are many theories that have been proposed, but the most commonly quoted theory is by Cohen. The principal etiologic factor is blockage of the drainage of interstitial fluid in a rapidly growing and rapidly remodeling area of cancellous bone. So, that is what is believed to be the most likely cause. Besides that, there are various other theories. One is about venous obstruction within the bone, the other is about congenital rest of synovial tissue leading to the formation of a synovial cyst within the bone, increased prostaglandin E2 levels, increased lysosomal enzyme activity and increased levels of cytotoxic oxygen free radicals. All these things have been found in the synovial cyst fluid and have been in some way connected to the formation of these cysts. Now the next important imaging that is helpful here is a MRI. In fact, in most cases, simple bone cysts are diagnosed primarily on the basis of clinical presentation and X-ray, but MRI also has its role. The typical thing that you would see on an MRI is a central unilocular fluid intensity lesion. It is a single cyst that you see, and that is really almost diagnostic of a simple bone cyst. If there is a pathological fracture, you may see a fluid level or a double density sign. But the important thing here is that you will get to see only a single double density sign. And the other thing that the MRI will show you is the true size or extent of the lesion. So this is an X-ray of a diaphyseal simple bone cyst, and here you on the MRI you see a unilocular single cyst. On biopsy, what do you get? What kind of tissue? In fact, you don't have any typical diagnostic histological findings of simple bone cyst. In fact, it is a diagnosis by exclusion. So, if the fluid has no diagnostic features, what you can find is what you will get from the scrapings of the walls of the cyst. The walls of the cyst are composed of fibroblasts which form a fibrous wall. So, the diagnosis is based on the clinical and radiological features and exclusion of other differential diagnosis. So, what is the differential diagnosis for a simple bone cyst? In fact, in majority of cases, as we already discussed, simple bone cyst is a clinical radiological diagnosis, but in some cases the other cystic lesion that we know of, aneurysmal bone cyst, can create a differential issue. Now, it is very important to differentiate these two lesions because they are treated very differently, they behave very differently. ABC, although it is a benign lesion, it is considered as a benign aggressive lesion. So, on clinical presentation, these patients will have complaints of pain and swelling even before they had any fractures. So, these patients come to you with a complaint. So, it is almost never an incidental finding. Patient has symptoms and some of them may even present with pathological fractures. On plain radiograph, what you see is it grossly has benign features, but some cases you may see some vague periosteal reaction. These lesions are also metaphyseal in location, they are also seen in this age group, but these lesions are more often eccentric. Of course, sometimes they can be central, and they are very expansile, and that is they evolve more in girth than in length, and this is a very distinguishing feature of aneurysmal bone cyst. And the other important finding is on MRI you get to see multiple fluid levels. If you see multiple fluid levels, simple bone cyst is out of your differential diagnosis. And on histology, again you see along with this cyst wall composed of fibroblast woven bone, and that again is differentiates it from a simple bone cyst. And nowadays you can also do some molecular studies. In about 70% of primary UBCs you get rearrangement of the USP6 gene. So this is proximal humerus ABC. It resembles simple bone cyst to some extent, but yes, there are features which tells you that it looks more aggressive. But this is what you do. If you follow this up, you will see that it is growing, it is increasing in volume. You would see a simple bone cyst, it would be almost the same. In fact, if there was a pathological fracture, it would have healed by 3 to 4 weeks. And on MRI, you see these multiple fluids levels. If you see multiple fluid levels, simple bone cyst is out of the picture. Aneurysmal bone cyst and possibly something even worse, what we call as a telangiectatic osteosarcoma, comes into your differential diagnosis.